And that takes us to the panel discussion. So as we introduced earlier, we have Dr. Tamer and we have Dr. Esmaeil, both, leading experts in their fields in the region, and we're thrilled to have you both here today. So I will just stop sharing my screen so we can see each other's faces. Without further ado, I have a few questions for you guys, if you don't mind giving us your insights. So for you, Dr. Esmaeil, I guess as an ophthalmologist in the region and as a medical director of Moorfields, I'm relatively new in the field, and you did touch on it earlier. I mean, in the region, sorry. You did touch on it earlier, how, coming into the region and seeing the benefits of Malaffi. Can you elaborate on, obviously, the integration of Malaffi, and as we've grown as an organization and, I guess the maturity of the system, could you elaborate on how important it is to have access to Malaffi and the integration there, and particularly in managing your patients that have multiple comorbidities, which typically your patient cohort would, if they're coming to you for, particularly the older generation, and how that would tie in with someone like Dr. Tamer and the care coordination that is required, and the benefits that you've found with Malaffi.
Thank you very much, Jocelyn and Mustafa, for that great presentation. And we're really excited to see all the new features coming in 2025. And honestly, every time Malaffi surprised me that you guys 2, 3, 5, 10 steps ahead, and that's really great to see that. But in direct answer to your question, first of all, I just have to say, with the Malaffi is really they give us all the advantage we need in terms of make us more efficient. For example, I get sometimes a patient, for instance, I had a patient only a few days came back with a pale optic disc, and we have a pale optic disc. There's many different causes, but one of them we have to exclude the ocular space occupying lesion within the brain. So all I'll have to do, just go on Malaffi, click, and there was an MRI for something else completely, and it got nothing to do with ophthalmology. And I got my answer. I know there's no space occupying lesion. I need to now concentrate on other causes of pale disc. Otherwise, that would be the first thing I would do. I have to send the patient for an MRI, wait another 4, 5, 6 weeks for MRI to come back. That comes negative, then go to do other tests. So you can see how much I've already bought myself 6 weeks of or 7 weeks or longer from the time. But also the fact that within that appointment, I could probably now make a diagnosis that now I've excluded, that now I know it's going to be more an ophthalmological problem. But that's just to give an example of how efficient it can make us. And a lot of time, once we get used to it, we actually forget the benefit it's providing us. But only when we endure on it and we'll think about it, you really realize that the efficiency that it will bring us, the cost saving for the whole organization, for the whole system, basically, of healthcare. As we know, healthcare is incredibly becoming expensive, and repeating an MRI scan or a CT scan, not just obviously have a lot of disadvantage and exposure to radiation for a CT scan, for example, or other investigation, but also the huge public cost saving, which ultimately benefits us all, basically. And of course, that will make us all to be much safer, practice safer, rather than exposing, as I said, the patients to multiple radiation or other tests and blood tests and so on. So from my point of view, it is a really game changing, and I'm really glad to see that you guys' perseverance on improving it further and further. And as I explained, honestly, the improvement I've seen since 2021 to today is just phenomenal. And now hearing from yourself, moving forward to 2025, and the chat box and the searchability actually is a great thing, because exactly like you say, sometimes we've got, obviously, as we go, the documents will get more and more, and it'll be very difficult to search where exactly that information is. So having that chat box, having that searchability is just unmatched, basically. Something will make it very easy to get information, because having information is one thing, but being able to access it in an easy way is another thing. And again, I'm really glad to see Malaffi is really having that holistic approach, not just of having a lot of data, but being able to use those data. So no, I'm really excited to be working in Abu Dhabi and over here, and having access to those patients' information. I'm not sure we answered your question, Jocelyn.
Yeah, that's fine. You answered a lot of questions, actually, so that's great. And I guess, Dr. Tamer, from your experience at Mediclinic, you guys have quite a robust EMR, and you've got a group of facilities within your organization. How has Malaffi benefited? I guess typically you'd probably see patients moving between the Mediclinic facilities, but also external facilities as well. How has Malaffi benefited you particularly in cardiology?
So actually, it's been a great help, actually, Jocelyn, in cardiology. Like I told you, ever since the launch in 2019, because it gives you like a comprehensive patient overview in cardiology. So you have the notes, you have the labs, you have the images, we have the echocardiograms, and then lately we'll be adding the ECGs. And this helps in managing the patient. So again, you check his medication history, so you don't do any duplicate medications. Sometimes the patients are unaware, like we get patients admitted and from the ER, they're not know what they don't remember the medication they were taking. So we used to check into Malaffi and see their medication, even the dose history, so that we can adjust it. Again, prevention of drug interaction, which had helped us a lot. And even patients who have seen actually cardiologists or same specialties in other facilities, you can read their notes, their follow-up notes, what the patient had undergone. And I'll give you an example. Before, we had one patient, he was having chest pain, so he went to the emergency in a facility, and when they did the ECG for him, they thought it was an MI, and he had a coronary angiogram which came back normal. Again, following year, he went to another facility, they saw the ECG, and then they did another angiogram, and then it's normal. 1 year later, same thing happened. So when he came and checked the data and seen that he's having the same ECG changes, and every time they do a coronary angio for him, it comes back normal. So this guy was being subjected to unnecessary procedures for nothing. So once Malaffi came in, when you have access to the patient's history and the patient's data, it helps you in managing the patient properly and preventing doing unnecessary procedures or investigations. So it was a great help, actually.
Super, thank you. Yeah, and I think what you highlighted there was the cost saving and the reduction in duplication of effort for the patient. And I think that is one major thing of an HIE in general, is that collaborative data accessible to you and to help you make those informed decisions, but also reduce the necessity to duplicate effort. And particularly, Dr. Esmaeil, you mentioned earlier how patients move between care providers here. You called it doctor shopping almost. Having something that visibility of that information can help, I guess, reduce that. And particularly the primary care model that DOH are trying to roll out over the next year will hopefully reduce some of that as well, where you've got a gatekeeper model as such to support that patient and oversee that patient's care with the support of the subspecialties. So having that visibility in Malaffi, and that will expand over time, will be a significant value add, I think, there. So thank you. Mustafa, I think you had some questions.
Yeah. Dr. Tamer, we love to hear stories usually. We like to hear stories how Malaffi did help the healthcare providers in more of a continuity of care. So you being a cardiologist, I'm sure you deal with patients with multiple comorbidities that they get referred by multiple specialties between internal medicine, ophthalmologist, and endocrinologist. So can you share with us how did Malaffi help in that aspect, in the continuity of care between different specialties, and how the diagnostics actually aided or facilitated this?
So actually for us, Dr. Mustafa, because our patients usually have multiple comorbidities, we get patient, for instance, with heart failure, you'll find an element of chronic kidney disease, probably diabetes, maybe diabetic retinopathy for Dr. Esmaeil. So multiple comorbidities. So with Malaffi, you have like a comprehensive picture. So for instance, I get patients and I can see the visits. He has been to the nephrologist and he has an element of chronic kidney disease. So then that in turn reflects on adjusting his medications from my medications. I cannot give him the full dose, for instance. I have to lower down the dose according to his kidney functions. Same thing, he has been seeing the ophthalmologist and he has diabetic retinopathy. Then I have to lower his blood pressure more. That puts him at high risk. I have to reduce his blood pressure. I have to control or send him to the endocrinologist for proper control of his glycemic index. Again, for us, we have something called the risk calculator for patients who have cardiovascular disease. So they're categorized as high risk, very high risk, moderate risk, and low risk. And actually, one of the points where we categorize them is something related to neurology. So then they have an atherosclerotic cerebrovascular disease, or so I can access that from Malaffi. He's been through the neurologist. He had a CT scan. One of them also is the carotid ultrasound or carotid duplex. So if he has a lesion there, that puts him at very high risk. Again, for vascular, we have the peripheral vascular disease. So if I see any imaging or he has visited the vascular surgeon and he documents that there is an incidence of vascular disease, that puts my patient at a very high risk or a high risk. And according to that, I have again to adjust the targets for his medications. So it's been a great help. And lately, most of our patients that we are seeing, we're actually opening the Malaffi portal just to check how they have been doing. Again, it helps us with the compliance. Have he been visiting like his nephrologist regularly? Have been visiting the neurologist regularly? So it's been a great help, and it's, like I said, an overall comprehensive overview of the patients, and it's actually a good tool, especially in these patients with the high comorbidities.
That's great, Dr. Tamer. We're so happy that Malaffi was able to help in that aspect. Dr. Esmaeil, since we talked on ophthalmology and we talk about the vision, we want to take you to the visions of 2025s and the ADPHCs and the disease registries. So in terms of the future vision of how Malaffi is evolving, how you would foresee platforms such as a disease registry of looking at specific disease, calculating specific risk of the patient, what kind of analytical dashboard that could actually impact your work positively going forward?
Thank you very much. So I think exactly like you said, the fact that we're going to have this data will give us a lot of real help while we're seeing the patient, but also how we want to use this data for our research, analysis, data gathering. And that actually will be an area which very much worth investing and spending time, because once we have so much data, it'll be very, very easy for us to do research, actually, for us to do audits, for us to do to look at various diseases, whether it's ophthalmology or another disease, look whether there's any correlation between one and another. And I think that's really the future of healthcare. That's the power of data. And given that now you're already being able to extract those data, have an AI algorithm looking into that, and being in a position where, for example, me as a healthcare provider want to look at X disease, I will be able to get anonymous data from Malaffi for multiple patients. And I think that's one area. I'm not sure at the moment what kind of consent process we have for the patients and sharing data for research purpose, but I think that's something it'd be well worth from beginning to have some sort of consent process for the patient, that we can use their data for research process. And of course, these data will be anonymous and they will not have patients' details or identifiable information. So I think that's an area which help us significantly. But in specifically with ophthalmology, as we said again, the fact that when a patient's come to me and there's been somewhere else and they've recorded their vision 3 months ago, 4 months ago, and I'll see the change in vision, that in itself become either an alarming or reassuring, depending on how it is. It could be, wow, the vision 1 week ago was 20/20, today is decreased by 3 lines. Why? And that again will give me that immediate urgency or non-urgency to do or not to do something, basically. So I think that's again, it's been a tremendous. But from my point of view, moving forward, it'll be really great to have that data available for research and development and devising a new treatment plan and seeing what is effective and not, basically.
That's great, Dr. Esmaeil. And I'm sure from a concept perspective and regulator perspective, DOH will be also looking at this closely. And I'm sure with the collection of data of Malaffi, as time go progress and the data matures more, gets standardized more, research and more publications will be in the scope, because that's the traditional improvement with the data. You first collect the data, standardize it, and then after that you build on it and you start predicting some patterns. That's great insight, Dr. Tamer and Dr. Esmaeil. Jocelyn, over to you if you have more questions.
Thank you. Just before, I'm just conscious of time, that's all. We do have Dr. Masood who has their hand up. I'll get to you very shortly. I just have one final question for our lovely panelists. In terms of, from a technology standpoint, are there any pain points, any things that where could you see Malaffi in the future? Or what are the top 3 things that we could do for you, I guess, to improve the efficiency that you need to undertake your roles? so that we can put them forward for suggestions. And I guess following that, we'll open the floor to questions. And Dr. Masood, thank you for your patience with your hand up. We will get to you very shortly, and then we can open the floor to questions.
Result, Dr. Tamer, do you want to go first?
It's okay, up to you, Dr. Esmaeil. So I'll will just say you guys have done a wonderful work. I know in the backstage you think it's easy, but I know computer stuff and programming and getting all this data and seamlessly, I know it's a hassle. So you guys been doing a great job. The only thing, like we discussed, is I think if we have like the whole, which you already started, the whole UAE. Is joined in Malaffi, where you can access the data. I know Northern Emirates are there, and soon Nabit will be there also, because sometimes you get patients from other Emirates and we don't have a history of their medications and their labs and all that. I think the integration of these two systems into Malaffi will be great. Other than that, I think everything like the AI, the search facility, that I think once you get multiple data, it's going to be difficult if you're looking for something specific. So I think the specified search options there. So if you're looking for something specific, you can get it readily and fast. I think you guys are doing a wonderful job, and we'll wait and see what surprise you have for 2025 and 2026.
Thank you, Dr. Tamer. Quickly, what would be the percentage of patients that would travel between or have care in other Emirates that you would see, just on average?
For me, about 10 to 15%.
Okay, interesting. Thank you. And yes, great suggestions. I agree. The connectivity to have it from a federal level makes sense. It's a small country. But obviously there's regulations, etc., based on different governments that manage the Emirates. So hopefully, in future, very, very shortly, that is the plan for 2025 to get Nabit connected. And then you will have that full access to the patient record. And then we will start optimizing the view of that. I know that it's not the easiest, given it's a continuity of care document, and they can be quite large, particularly patients that spend a lot of time up in other regions. Or the elderly population who have a lot of medical information. So we'll start optimizing that in future as well. Over to you, Dr. Esmaeil.
Thank you very much. So from my point of view, one thing, it is great to see that you've had now the encounter view, where I can see the patients, which hospital, which doctor, so I can go exactly, like, for example, to ophthalmology or radiology or whatever specialty they've seen. So that's really, really great thing to see. But I thought what could probably help us as well, where you've got the documents, and on the documents at the moment, it shows the dates that the documents was being put in on the panel. So when you expand it, it doesn't show me which hospital or which department or which specialty. I think it'd be really, really useful if somehow within document, as soon as you expand it, on the headline, we have the date, and next to it we'll see, for example, Moorfields Hospital Ophthalmology. So whoever looking, for example, they know this is an ophthalmology that because sometimes I'm looking for ophthalmology only, sometimes I may be looking for cardiology, for example, or another specialty, or for even specific hospital, because patient told me a story, something happened at that hospital, so I want to go straight to that note, see exactly what happened, or the patient had the surgery. So I think it'd be really, really useful within that document when you expand it, if you had those categorized, not just by the date, by facility name and the specialty. I think that will be, again, I'm sure you're already working on a lot of these, making it so easy for us to gather information, but then having that, I think it will add quite a bit. But I think another thing, which I'm sure you're already thinking about it, is looking at the chronic diseases or diseases where there is screening required, for example, whether it's diabetic retinopathy, diabetes, or anything else, that screening and notification will comes up. And I'm sure you're doing a lot of work on that regard. But for us, for example, ophthalmology, one area which can cause a severe bilateral blindness is what we call retinopathy of prematurity. It's babies who born premature. If you don't screen them, you don't do specific treatment for them while within weeks of getting born, first 4, 5, 6 weeks, they could go permanently blind. And for example, in UK, we used to have this huge problem where the patients, because there's no availability bed, they go from one hospital, they get born in one hospital, then they go to another hospital, and then they get missed that they need a retinopathy prematurity screening, and actually a lot of patients went blind. And what they did there in UK, they created a system just for that. So when the patients go between neonatal unit, there will be straight away a notification saying that this patient's need his second retinopathy check in a week time. So I think if we add that, I know that's more inpatient, not outpatient, but I think that's an area which given that a lot of babies surviving premature baby, and given the fact that it could causes bilateral blindness, it'll be great to add those modules, not just for ROP, but it could be also for other areas of specialties where they are very, very high risk, where when the patients go to wherever, that notification will comes up. So I think that will add quite a lot of benefits and deliver a lot of the benefits to us.
Very great suggestions, thank you. And hopefully, I guess in the short term, maybe some of the LLM or the smart search features might help with navigating in particular the document types. The alerts may help. That as Mustafa said, that's something that we plan to focus on this year as well. Excuse me, next year. So perhaps building that into, I guess the schedule, similar to the vaccination schedule, for other areas of interest, may be something that we should consider as well. So thank you so much for those suggestions. That's fantastic. I'm just very conscious of time that we're at 9 o'clock now, and then we may have some questions. Firstly, I'll just open the floor we'll start asking if anyone has any questions. Obviously, Dr. Masood is there.
Jocelyn, I think we have a question on the chat by Dr. Muhammad Barka.
Oh, sure.
So, yeah, if you would like to address this. So Dr. Muhammad is asking us if we start integrating the data that is coming from remote patient monitoring, such as the remote or continuous glucose monitoring, for an example.
Sure. Do you want to take that one?
All yours.
Thank you, Dr. Baraka. To date, no, we don't have integration with the glucose monitoring from a patient perspective. Perhaps if it's going into the EMR, then we could receive it in Malaffi in future, or perhaps if the wearables through Sahatna. So Sahatna is a patient application, as many of you would know, and that will be now used as our, I guess, patient application as well. It feeds into, we previously had the My Health Record, Malaffi Health Record, which was the patient application. Now that information is in Sahatna. So if anyone lives in Abu Dhabi, you can download that. If you've been a patient somewhere, I highly recommend it. It's a great tool. But through that, there are a lot of wearables that patients can, the data from the wearable is being pushed into Sahatna. Maybe in future, something like the glucose monitoring tools from the patients may come in and feed into the system itself versus just sitting siloed in Sahatna. But to date, no, sorry, we don't actually integrate with that yet, but it's something that we are considering. Thank you for that. I hope that answers your question. Dr. Masood, you've got your hand up. Thank you for your patience.
Yeah, Dr. Masood, you can now just unmute yourself and you will be able to speak.
Thank you very much to give me this opportunity. It is a really great, and I see this information available in the Malaffi. It helped a lot doctors to have a better idea about the health situation of every patient. And I have to thank all of you that you are still working to upgrade and update this information in the system. Now my question is general, not a specific field, and it is forwarded to Dr. Mustafa. Dr. Mustafa, with everything positive in the life, there are negativity as well. So can you mention anything negative about this system, if you have any?
From an HIE perspective, from a Malaffi perspective, Dr. Masood?
General, about everything in this system, from the a small part to all the information available on the system.
So, Doctor, as you rightfully said, in every single thing in the world, there are positives and there are negatives, and it depending really on the utilization of the tool itself. We can sit here as an example and argue that social media is bad or social media is good. You will find people that are advocate for the social media. It's a good tool. It's an informative tool. They get information that they were never reached to. And you get another people that they will see it from a different perspective. For my perspective, from all the electronic medical record and all the technology that goes into electronic medical record, it depends on, it's in the end, it's a tool. It depends on how me as a healthcare provider, as a healthcare enabler, I'm going to use it. It's not going to replace my clinical judgment. It's not going to replace the patient who is in front of me. Me dealing with the patient, me having this trust between a healthcare provider as a patient will always be there. Now, in case that if I decided as a healthcare practitioner to depend on technology and detach from the patient, then this is a negative thing. But we can't blame this on the technology itself. But as an example, and I was working before Malaffi in implementation of EMR systems. So basically my whole career was to move the hospitals from a paper-based medical record to an electronic medical record. Was it having some downsides at the start? Yes. But then what I have noticed is the more it gets adapted to the daily life and the daily activity and how you think of it as a healthcare practitioner, of how it will help you, yes. Now, if you misuse it, it's like any other tool. It's like your car. You can drive it, enjoy, take your family, enjoy rides, or you can drive it recklessly and then it will wreak havoc on your life. So I think of it from the same way. It's an enablement tool. The negatives, of course, if I'm depending so much on it that I forget my own clinical judgment, then that's not good. And if I neglect it totally, then that's not good. It's a tool. It's information that is available. You can use it as you see fit in your clinical judgment. If you overuse it, then that will not be a good tool. So I would always consider the tool as a neutral, and it's depending on me as a healthcare provider of how I want to leverage it and use it. And I hope that answers your question.
Yes or no, because I will open your eyes in other perspective, let's say.
Sure.
Before this system availability, and there was all this information on medical condition of the employee or patient available in the system, people, they were submitting all their CV for recruitment in the companies. Mm-hmm. Now, with having all this information, this is sometimes has negative impact on the recruitment of the people, because they get unfit due to their condition and they cannot get the job.
Now, again, here I will take it from the other way around. So healthcare record, they already compliant with the privacy. Ideally, the people who get access to the health record are only healthcare practitioners, basically, and it should not be misused. And there is a lot of a privacy that we abide by Malaffi, and there is a regulation on how you use the healthcare information. Healthcare information cannot be misused. I cannot, as an example, as a recruitment company, have an access to the healthcare data of the patient and then take this data and then judge the patient ability to do the work. That shouldn't be the case. This is, again, is a misuse of information. And forget the technology. Let's go back to the paper age. If I'm a recruitment company and I went to the hospital and I asked for the medical record and the hospital gave me that medical record on paper and I took it and then I based my decision on recruiting the guy based on this, then again, this is not the fault of the file. This is not the fault of the medical record. This is the fault of the handling the privacy of the patient record. Patient record and privacy, it's already a sacred. And there is already a lot of regulations that well known internationally as a standard of how the healthcare information should be handled. Whether it is on paper or paperless, it's the same.
So how you get the fitness from a doctor?
Sorry for the interrupting. I have to be leaving now. So thank you so much.
Sorry, Dr. Esmaeil.
Thank you. Bye-bye then.
Thank you so much, Dr. Esmaeil. Take care. Thanks again. Have a great day.
Thank you.
You know, for example, pilots, they need the fitness. Mm-hmm. And the fitness, they are getting it from the doctor. So doctor has access to this information. And according to this information, he will give his fitness. That's right?
Yes, that's 100% right. But again, Like the fitness is a criteria, right? I mean, the criteria doesn't have to do with the abundance of the information or not abundance. I will just always get it back to the misuse of information. I'm an airline company. I do have my own internal policy of how I want to recruit. Fitness of the pilot is important because it is linked to the safety of the passengers. Again, if I am going sneaky, misuse the information, I can do it with technology or without technology. Easy access to information doesn't prevent abuse of the information. And we are so happy, Doctor, even with Justin and myself, just because we are conscious of time, we can take this offline, have a separate meeting with you and address all your concerns from privacy. We are 100% ready to do that. You can leave us your contact and email. I'll be more than happy to contact you.
I appreciate it. Thank you very much.
Perfect.
Thank you, Doctor. Thank you.
My pleasure.
Thank you,
Jocelyn, we have a call. We have also a question on the chat from Hassan Imam. He's asking about the privacy and the privacy seal. If you could shed some light on that.
Sure. Some privacy, sometimes all information are hidden. Sometimes part of it is what is the difference. Right. So breaking the privacy seal. So I didn't actually mention it in the demonstration, but you may have missed that part in the education piece. But what is required for Malaffi is obviously, as you know, it's mandatory to connect, and it's not an option to opt out at this point in time. So to support patient confidentiality, certain areas or information is seen as sensitive in Malaffi, and that's typically around certain diagnoses that sit under either behavioral health, infectious diseases like your HIVs, your hepatitis, mental health, substance abuse, and fertility are typically your sensitive areas. So anything that sits under that is seen as sensitive, and you need to break the seal, similar to an EMR, like you need to break that glass as such to access that information. Now, when you do that, we audit it. So we look at who does that on a regular and can track that. So it is audited and monitored. It remains open for 1 hour, and when it happens, it breaks the whole, anything that's sensitive in the patient's record will open and be available to you. Now, this is typically only for level 1 users. So Malaffi has select roles based on the individual user's needs. So physicians are typically level 1 users. You may have some nurses who might be level 1 as well, you know, your emergency nurses, your triage nurses, etc., or some of your pharmacists, but typically it's for physicians. So in terms of that information is not typically visible to you until you break the seal. Obviously, it was a requirement from the Department of Health and us, and obviously the select areas were approved by the Clinical Advisory Committee, which I guess governs us and supports us with our, I guess, how we've rolled things out with Malaffi. I hope that answers your question. So you need to break the seal before you can actually access that particular information. It's usually your diagnosis, so in your encounter, any procedure that sits under those 3 areas, or 5 areas, any lab result or any clinical documents. So if your patient had, you know, a psychiatry admission, that would typically be a sensitive encounter. You need to break that seal to see that information. Thank you, Dr. Hassan. Dr. Layli?
Yeah, the mic is enabled, so you can unmute yourself and please go ahead.
Good morning. I'm Dr. Layla Hashmi, endocrinologist from Mediclinic. Thank you very much, and congratulations for this really achievement, because it helps us too much. I want to ask something. Sometimes see the consultation and the different doctors seen by the patient, but still for some facilities we cannot see all the lab tests. I don't know if there is a problem with the download of this data, or because some facility doesn't upload until now all the lab tests, because it's important for us to see the A1C, the last lab test done by the patient, but still there is a lack of information about the lab test for some facilities. And for these same facilities, sometimes we can find the data, and sometimes we cannot see the data. I don't know what happened.
Yeah, Dr. Layla. So in terms of the connectivity, Malaffi is connected to almost 100% of the market. Now, in terms of our onboarding, which is, as an example, how we are reaching out the providers and how we are reaching out the market in order to onboard them, this comes sometimes into phases. So as an example, from Malaffi side, we are receiving a platform, and then we go and then example, we go to each and every facility and then we onboard them. Some of the facilities might have a little bit of a technical challenges, so they are unable to send us a certain data domain. So our onboarding team works with them continuously to get them up to speed to send us this information. Another thing is that sometimes we do a data quality check. Our data quality check can have on two levels. One of the level is on the receiving level. So as an example, if the information is sent to us lacking a vital parts, then basically we reject this message and we ask the facility to resend it to us. So in terms of Malaffi not having the result, it could be either that the facility is not yet connected with their laboratory and our onboarding team is continuously working with them, or it could have been that they send us the data lacking vital information that could compromise the clinical integrity of the data. So we reject the message, giving them the feedback to resend it to us. And we have another team that deals with this case. Sometimes there are technical challenges, and this is all we are aware of, and it is a continuous process that we have to ensure the completeness of it.
Thank you so much.
My pleasure.